So I guess we'll get started in the interest of time. So good afternoon, everyone. Welcome to Cardiology Rounds. So again, it's my great pleasure to have our guest speaker, Dr. Subodh Verma. He's well known to all of us. He's a professor actually in the Division of Cardiovascular Surgery and also Pharmacology at the University of Toronto. He also holds a Canada Chair. Again, has many publications and has led important international trials, including the ones I will be talking about today, which will include the STEP-HFpEF and the SELECT actually program. Thanks, Subodh.
Thank you, Andrew. And really, I hope I'm not a guest, right, Andrew? We're part of the same family. I hang out with you guys.
Yeah.
I hang out with all of my friends from cardiology as much as so. It's my great pleasure to be here. It's an exciting time, and I just wanted to give you a quick update from the ESC meeting from these two programs. But it was a remarkable ESC for the University of Toronto. Jay Udell and Sean Goodman had a bunch of New England papers, and there was lots of excitement. So it's always nice to go to these meetings and see that our Canadian colleagues are continuing to sort of be at the global stage. And there's a lot more excitement coming, at the AHA meeting with some trials that Kim and I have been involved in that will be presented as a late breaker as well. So I'll showcase that with you and give you a bit of a landscape as to where things are going. In addition, I'm sure Kim and Andrew, you guys have had a discussion internally. Trials that we weren't involved in but have great clinical significance for our structural program were presented. Stefan Anker presented the ReShape-HF results, which you may have already discussed at Cardiology Rounds. Then there was the tricuspid clip study that was presented. As you know, there were some controversies around TRI-Illuminate, and then the sort of recent data now. So there's a lot of good insights regarding the sort of structural mitral clip and the tricuspid clip that are also worthy of sort of consideration. And Andrew and Kim, Stefan Anker has sent a note to me saying he would be happy to present at Cardiology Rounds. So if you would like to do that, I can connect the dots with him, and Kim, you know him personally as well. So I'm just going to tell you a bit about where this program is going, because it's the basis of STEP-HFpEF and some analyses from SELECT that in the next 6 months you will see a series of big trials from different incretins being launched in the space of heart failure with preserved ejection fraction. So what I would like to do in the next 30 minutes is just remind everyone about the STEP-HFpEF program and the overall results which I presented at Cardiology Rounds. I would like to share with you some key sub-analyses that we have published. There have now been 11 sub-analyses that have been published, but of course we won't go through all of them. I'm going to speak a bit about the sex analyses, the analyses by atrial fibrillation, the inflammation analyses, the NT-proBNP analyses, and then finally the echo analyses that have now been all presented. All of these sub-analyses are now available in JACC. I will also present to you the pooled analyses of clinical events, because as you know, STEP-HFpEF was a trial that looked at primarily patient-reported signs and symptoms of heart failure using KCCQ clinical summary score. But now there's pooled analyses data looking at clinical events of heart failure, hospitalization, and cardiovascular death. And I will share those with you, along with, just some insights around the summit result that will be presented as a late-breaking clinical trial at the AHA, and then just end with a couple of comments on sort of where are we heading in the pharmacological treatment of HFpEF with the top-line results of the Fine Arts trial. So I always like to start a heart failure lecture with, Professor Brownwall's paper in The Lancet from 2014. It's one of the most wonderful papers that I've ever read that reminds us that, we are really at war with heart failure. We're winning in some domains, we're losing in other domains. And as you may have seen, recently in JAMA, there has been the statistics from the United States suggests that 3 decades of mortality gains that we have made in heart failure are slipping away, and there's been a rapid reversal in mortality from heart failure, largely because of demographic aging, but mostly because of overweight, obesity, and diabetes. So despite all of our efforts at improving pharmacological treatment of heart failure with preserved ejection fraction, if we don't really win on the epidemic of overweight, obesity, and diabetes, I think we will continue to lose the war. And therefore, it requires both pharmacological and, of course, lifestyle and societal interventions. The magnitude of the problem is large, and HFpEF continues to be the largest contributor to this increase in heart failure burden. Now, as you all are aware better than I am, there have been no prior trials and no prior therapies in obesity-related HFpEF phenotype. Now, as you again know, for some of the trainees on the line, HFpEF is a disease that has more editorials, more classifications, more hypotheses than any other disease. And we, I think in 2023, have now settled on 3 different phenotypes of HFpEF, of which the cardiometabolic or obesity-related phenotype is one that we believe is the dominant form of HFpEF, where visceral adiposity actually is a central player in the pathophysiology and genesis of HFpEF. And this is a paper from Current Opinions in Cardiology that Kim Connolly was the senior author on, and just highlights the fact that visceral adiposity triggers insulin resistance, it triggers immune dysregulation, macrophage polarization, increased adhesion molecules, quite profound T regulatory cell dysfunction, local and systemic activation of cytokines like IL-6, IL-1 beta, TNF alpha, changes in myocardial fuel utilization, which then in turn trigger microvascular endothelial dysfunction, myocardial fibrosis, concentric remodeling, changes in compliance, diastolic dysfunction, atrial remodeling, myocardial steatosis, that's a spelling error there, all of which actually contribute to the pathobiology of HFpEF. So we do think that targeting visceral adiposity could have a primary, if not primordial, role in changing the natural history of people with heart failure and preserved ejection fraction. And it was with that sentiment that we went forward and did these 2 trials in the STEP-HFpEF program, STEP-HFpEF and STEP-HFpEF-DM. As you're all familiar, these are trials of people with BMIs over 30 kilograms per meter square. They have symptomatic heart failure, and they have to have heart failure with preserved ejection fraction, very carefully defined with either filling pressures, natriuretic peptides, or strict criteria for E to E prime ratio, E prime velocities, or a prior hospitalization for HFpEF with ejection fractions above 45%. There were 2 sister trials, as the regulators actually asked us to do that, primarily because the weight loss in people with diabetes tends to be less than the weight loss in people without diabetes, and that needed to be sorted out carefully. And as you know, the overall result in people with or without diabetes was quite consistent with respect to the improvement in Kansas City Cardiomyopathy Questionnaire. And all of you are quite familiar with this. This is a validated measure of patient-reported signs and symptoms of heart failure, physical limitations, social limitations. It actually has a regulatory path. And you can see very early after treatment with semaglutide 2.4 milligram once weekly by 20 weeks, an improvement in KCCQ was observed that remained consistent. And by 52 weeks, there was about an 8-point difference in KCCQ. There was about an 8.5% change in body weight. But as you will see in the next slide, there was greater body weight reduction in people without diabetes. As you can, let me just use my pointer. As you can see here, people without diabetes lose about 10% of their body weight. People with diabetes lose about 6% of their body weight. And the reason for that is that people living with diabetes are insulin resistant. And when you're insulin resistant, again, the effects on weight loss are blunted. And the change in KCCQ clinical summary score, however, was very consistent in both of these groups. So the STEP-HFpEF program, in our opinion, is important for a few reasons, and I'm going to highlight that and showcase some of the new data to you. One is that the magnitude of the improvement in KCCQ is quite large. And in fact, this steering committee here for STEP-HFpEF wrote a sort of opinion piece coincident with the publications of the primary paper that just showcases the magnitude of KCCQ improvement that is seen with semaglutide in obesity-related HFpEF relative to everything else that we have seen in heart failure with preserved ejection fraction. Now, please remember, this is an opinion piece, it's not a randomized trial, and therefore these are indirect comparisons that are flawed statistically, but nonetheless, it gives you an idea of the magnitude of improvement in KCCQ relative to other things that we've done, including the results of finerenone you've seen recently in the fine arts study that improved KCCQ by about 1.5 points. So the 8 to 9 point improvement that is seen here, or the 8-point improvement, is of a large clinical and statistical significance. Now, surprising to many, angiotensin receptor neprilysin inhibitors, SGLT2 inhibitors, do not change 6-minute walking distance at all in HFpEF. And in fact, the improvement in this secondary outcome of 6-minute walking distance that we observed also stands in contrast to what we have seen with other trials in HFpEF. The second important sort of message from this program is that we did not have data for this last time I presented, and that is that the benefit is seen with respect to all of the domains in the KCCQ clinical summary score. And we have published this earlier this year in Circulation, and you can see here that in addition to KCCQ clinical summary score that you and I think about more highly, patient-reported signs and symptoms of congestion and physical limitations. There are other domains to KCCQ that were also evaluated, including, the social limitations score. And, this is a quite interesting score that has not been responsive to any other therapy in the past in heart failure, period. And this is social functioning, partner relations, family relations, things that are important to people and patients with heart failure is also improved with semaglutide. Now, the elephant in the room, if I may, with STEP-HFpEF has been, great. This is a step in the right direction in terms of improving patient-reported signs and symptoms of heart failure. But what about hard clinical events? And, hard clinical events in clinical trials of heart failure are defined as really CV death or heart failure hospitalization. And, as you can imagine, we were not powered in STEP-HFpEF or STEP-HFpEF-DM to have enough clinical events to be able to say anything other than, numerically fewer clinical events occurred, but they were not definitive per se. And you can see here in the 2 individual trials pooled together, there were few events over 1 year, but they seemed to be numerically in the direction that favored semaglutide for CV death and heart failure hospitalization. But at the ESC meeting this year, we have pooled the results of several trials, STEP-HFpEF, STEP-HFpEF-DM, the SELECT trial, and the FLOW trial across the various trialist groups. And we have looked at individuals with heart failure and preserved ejection fraction, and then looked at hard events. So what you can see here in the next slide is something quite interesting and I think clinically meaningful for all of us. And that is that when we now look at hard events of cardiovascular death and heart failure hospitalization, you see that there's a 31% relative risk reduction with a p-value of 0.0045. Now, again, this is not a prospective randomized trial of a sort of a homogeneous population, but I think it's getting one more step closer to the truth, and that is that in people with heart failure with preserved ejection fraction across 4 trials, that semaglutide is associated with a significant reduction in the so-called hard events from heart failure, and that seems to be driven entirely through reduction in heart failure events or heart failure hospitalization or a worsening heart failure event with hazard ratio 0.59. But there was a numeric but not statistically significant reduction in cardiovascular death. And that's not uncommon, as you know, that's not uncommon in the context of HFpEF populations. The next comment I'll make is around the broad generalizability of these data. At the end of the day, trials are only important if they can be used in the populations that we study. And as you see here, we have again demonstrated the efficacy of this therapy across all demographic and clinically significant subgroups that are shown here. There are a few exceptions where the benefit seems to be exaggerated, and there's a few examples where the benefit is slightly lower, and I'll talk a bit about that in the next few minutes. Now, again, as all of you know quite well, that sex interacts quite uniquely in the context of heart failure, and particularly heart failure with preserved ejection fraction, which tends to have a higher prevalence of female sex compared to males. And also the outcomes of females versus males with heart failure with preserved ejection fraction are unique. And, the Frank-Starling curve is unique in females compared to males. The echocardiographic sort of cut points and thresholds across the range of HFpEF and HFrEF and heart failure with mildly reduced ejection fraction are also greatly influenced by sex, and pharmacological strategies have had a sort of distinct effect across the range of ejection fraction by sex. And I'm referring primarily to MRAs and TopCat and of course ARNIs in the Paragon and Paradigm program. So evaluating this subgroup, I think, is quite relevant, given that 50% of the people we enrolled in STEP-HFpEF were female. So we published these data again earlier this year as an update from the program in JACC, and these were the key findings from that 50% of people with obesity-related HFpEF were female. Females had a higher BMI compared to males. Also, females with obesity-related HFpEF tended to have worse symptoms, worse physical limitations, and worse exercise capacity, despite having a higher left ventricular ejection fraction. They also had higher levels of inflammation as evaluated by CRP. They tended to be younger than previous HFpEF trials. So despite being younger, despite actually having higher ejection fractions, they actually had worse symptoms, physical limitations, and exercise capacity. They did have greater impact in terms of weight reduction compared to males. They had a lower use of SGLT2 inhibitors, but what you can see here, despite females losing more weight with semaglutide compared to males, they had a consistent improvement in KCCQ clinical summary score. And this is one indirect sort of piece of evidence that it's not all weight that is driving this benefit, because oftentimes people look at this trial and say, the improvement in KCCQ clinical summary score, the improvement in outcomes is all driven by weight. And we now have several examples where there's greater or lesser weight change, but those greater or lesser weight changes do not necessarily follow the same direction of either greater or lesser improvement in KCCQ clinical summary score or events. Neither do they follow the same trajectory or temporality. as we've seen earlier. So, weight is an important component for sure, but it's not the entire story, as you can see here. Now, another important aspect of this program that has now been updated is that there is quite significant reduction in diuretic use, which, again, has been the only therapy that has been available in HFpEF for a long time prior to SGLT2 inhibitors. And these were data that initially were presented at the European Heart Failure meeting and now are in press in the European Heart Journal. And you can see here that the odds of loop diuretic dose decreases are 2.67. The odds of a loop diuretic dose increase are 0.35. So 65% chance of decreasing dose of loop diuretic and an odds ratio of 2.67 to decrease the dose of loop diuretics. And then there's a reduction in furosemide equivalent doses with semaglutide in HFpEF. There's also a very early improvement in NYHA class in obesity-related HFpEF, and Mark Petrie and one of his colleagues from the UK, along with the team, have now also presented this in JACC. And you can see here that by week 20, there is a significant improvement in NYHA class that is statistically significant. And by week 20, there's also a numerically less deterioration in NYHA class that is, again, goes hand in hand with some of the earlier data that I've shown. Now, is this truly a disease-modifying therapy or not? And to try to really get to the bottom of this, we've done a careful analysis from STEP-HFpEF, again, also in JACC, looking at the NT-proBNP analyses. And as you know, in people living with overweight and obesity, natriuretic peptide levels, because of various kinetic reasons, tend to be much lower. And that is mostly due to volume of distribution and pharmacokinetics of NT-proBNP. And as a result, when people lose 10% of their body weight, for example, with semaglutide, you would expect, as has been seen in other trials of weight loss, that the natriuretic peptide levels actually paradoxically, or not paradoxically, they actually are higher because they re-equilibrate based on loss of BMI. So if in the context of weight loss, you are able to demonstrate a further reduction in NT-proBNP, that really is a sign that there is quite significant decongestion occurring with this therapy. And that's what we found here, that despite weight loss, there was a reduction in natriuretic peptides, which really tells us that, there's a reduction in stretch, there's a reduction in, myocardial stretch, there's a reduction in congestion with semaglutide compared to placebo, which argues for a disease-modifying effect of this therapy in heart failure. Now, another update that I think is relevant to discuss today is this interface between overweight, obesity, and inflammation. As you know, the diagram that I showed you earlier from Kim's paper in Current Opinions really highlights the centerpiece of this entire thesis being visceral adiposity driving inflammation. And inflammation, whether it's macrophage polarization or adipokines, or whether it's through changes in T cell and adaptive immune regulation, seems to be at the fundamental process that really drives this phenotype. And the question that we had in this program was, does baseline level of inflammation matter? And does the amount of weight loss parallel the amount of benefit that is seen? I think this is also a very important question because many of you are aware, Gordon is aware and involved, that there are sort of targeted inflammation therapies that are being tested in HFpEF. There's the ongoing trial called, what is it called, Kim? Hermes. With ziltivekimab that is looking at a targeted approach for inflammation. in people with high CRP who have HFpEF. And I think a few groups are kicking the tires with colchicine and others in HFpEF, and there's other therapies that are evaluating this. So, many have thought that semaglutide is an anti-inflammatory. And if that is the case, then people with obesity-related HFpEF who have more CRP or more inflammation should actually be the ones deriving greater benefit. So we presented these data and also published them in JACC at the ESC meeting this year, looking at that question. But we were surprised by the fact that baseline levels of CRP made no difference whatsoever to the overall efficacy of semaglutide versus placebo on either body weight or an improvement in KCCQ. And therefore, we concluded here that, if semaglutide's dominant mechanism of benefit was indeed through inflammation reduction, which it does reduce CRP, then you would argue that people with more inflammation should derive greater benefit. But as you can see here, that was simply not the case. The other interesting observation that many have said happens is that if you lose more weight, you're going to lose more CRP. You're going to reduce your CRP to a greater extent because the central adipose tissue appears to be really the one that drives, inflammation. But again, a very interesting observation was made here, and that is that the magnitude of weight loss, 5 to 10, 10 to 15, more than 15 or more than 20, with this therapy really made no difference to the magnitude of CRP reduction. So again, the CRP reductions with this therapy seem to be agnostic to the amount of weight loss that was observed. And finally, this is a sort of tantalizing and hypothesis-generating observation that whereas for KCCQ and 6-minute walking distance, we did not see any relationship between change in CRP and the efficacy for this outcome, we did find that semaglutide seemed to have a greater effect to reduce NT-proBNP levels based on greater reductions in CRP. So there may be sort of an effect here between inflammation, natriuretic peptides, and CRP that we are actually observing. But again, now this is a analyses and sub-analyses of another sub-analyses, but it is something that, again, is hypotheses generating. But the top line is that inflammation does identify people at higher risk with inflammation, does identify people who have greater signs and symptoms and burden of heart failure in the STEP-HFpEF program. But the level of inflammation did not identify a population that was uniquely poised to derive greater benefit with this therapy. But there is a population in STEP-HFpEF that is uniquely poised to derive an even greater benefit. And that is those who have coincident atrial fibrillation. Now, first and foremost, let me tell you that AFib in the STEP-HFpEF program was investigator reported. We did not have an ECG. We did not mandate that at when people were enrolled. So this was a history of AFib. Now, we did look at, subtypes of AFib, persistent, paroxysmal, permanent, etc. It made no difference. But what was very intriguing here, and again, we presented these data as a late breaker at the ESC and also published these simultaneously in JACC. You can see that the population of patients with AF actually were the population that derived the greatest benefit of semaglutide in obesity-related HFpEF. Actually, the magnitude of benefit in people with obesity-related HFpEF who have atrial fibrillation is 3 times greater than people who have obesity-related HFpEF who don't have atrial fibrillation. Now, the mechanism and the reasons for this are unknown to us, but it certainly clinically is a valuable pearl, and that is that if you're treating someone with obesity-related HFpEF who also has coincident atrial fibrillation, then this might be a very important population. Now, Kim and I have been chatting a lot about this to say, does the drug prevent incident atrial fibrillation? And we collected that information as AEs. there were numerically fewer new AFibs because treating obesity could reduce incident AF, but they were just not adequately powered to make any conclusions around AF prevention. But there are many trials that are currently being planned with this strategy in that space. Finally, the results here were concordant with SELECT. Now, as you all know, SELECT is a trial not of heart failure, right? SELECT is a trial of 17,604 individuals that have ASCVD, either prior MI, prior stroke, PAD, who actually are overweight or obese, but do not have diabetes. And this was an anti-atherosclerotic trial that demonstrated the benefit of semaglutide to reduce atherosclerotic events. But there was a population of people here that actually had heart failure, either heart failure with reduced or heart failure with preserved ejection fraction. In fact, a quarter of these patients with ASCVD without diabetes actually had heart failure. So John Deanfield and I led this analysis from the SELECT trial, also was presented at the ESC and published simultaneously in the Lancet, that demonstrates that semaglutide in that population of people with heart failure, a quarter, that either had heart failure with preserved or heart failure with reduced ejection fraction, was associated with a reduction in cardiovascular events and heart failure hospitalizations, with again hazard ratio 0.65 and 0.69. So again, this seems to be a medication that does have a heart failure signal for sure, and that seems to be seen across the ejection fraction. Now, Dr. Scott Solomon from Brigham and Women's Hospital was the core lab for echocardiography in the STEP-HFpEF program. And at the ESC meeting, we have presented the echo sub-analyses from the STEP-HFpEF program. And this was led by Scott and John Otraminsky from Brigham and Women's Hospital. And they looked at, again, it was published also in JACC, that of the patients in the program, 491 participants actually had echo data that were available in obesity-related HFpEF. They were the pre-specified primary endpoint of the echo analyses from baseline to 52 weeks was a change in left atrial volume. And what we found was that semaglutide resulted in a reduction in left atrial remodeling. This reduction in left atrial volume was consistent irrespective of age or sex or BMI or level of natriuretic peptides or CRP, diabetes status, AF, EF, or background therapy. Now, things that I don't understand very well, and I've been bothering Kim about this to sort of just get the context a bit better, and maybe he'll offer some comments at the end. But we also found that it improved E-wave velocity, E to A ratio, E to E prime average, and also promoted right ventricular remodeling compared to placebo. But it did not impact on LV mass or LV mechanics or LA strain per se. So don't ask me any questions about this, direct them to Kim. But the bottom line is that with respect to left atrial remodeling or left atrial volume, which was the pre-specified endpoint, it was reduced. But what was interesting is that reduction in left atrial volume appeared to parallel the degree of weight loss, as you can see here. However, other measures such as change in E-wave velocity, E to E prime average, and right ventricular end diastolic area, it's the first time I've heard of that index, were not associated with changes in weight per se, suggesting there could be weight-independent benefits on sort of echocardiographic measures of left ventricular and left atrial remodeling. So all of this to say that these benefits are seen in the context of safety. Maybe this should have been the first point that I make, that therapy was safe. SAEs were fewer. There were more discontinuations due to gastrointestinal side effects, consistent with what we know with this program. So just to sort of look into the future, where are we headed? you know, the tirzepatide program, and all of you are aware that tirzepatide is also marketed by the name of Mounjaro in Canada. And this is a dual GLP-1 GIP co-agonist or dual agonist. It is superior to semaglutide in terms of weight loss. It has consistent benefits on cardiometabolic risk factors. And the SUMMIT clinical trial that is being led by Professor Milton Packer has now presented its top-line results in a press release. The entire trial and its sort of various components, including an MRI sub-analyses, will be presented at the AHA this year in Chicago as a late breaker, or late breakers, there's a few. And the top-line results here is that tirzepatide has met its primary endpoint, which includes KCCQ, but also includes heart failure visits and heart failure hospitalizations, diuretic intensification, or cardiovascular death, and has shown superiority by 38%. So this is really important because now it's not only confirming what we saw in STEP-HFpEF, but it's extending that to actually now have a prospective study where there are clinical events. Again, we'll have to see what the details are when the trial are presented. And you can see here the hazard ratio that is now being disclosed in the public domain of 38%, a hazard ratio 0.62, p-value that is 0.026. So the field of incretins is moving fast and furious. And, it is truly been serendipitous that we have learned so much from our endocrine colleagues about the sort of the therapy and as many of you have been mentored by Larry Leader and Alice Cheng and Bernie Zinman and Dan Drucker, the mavens of the sort of diabetes field, learning the language of the Richard Gilbert, the SGLT2 inhibitors. I couldn't even say gliflozin, when I first was introduced to that. And then the SGLT2 inhibitors became cardiometabolic and renal drugs. Likewise, GLP-1 RAs, semaglutide and tirzepatide and retirotride and survodutide and orforglipirone and all these new therapies are on the horizon that are now not only drugs for people with diabetes, but are entering in full-fledged steam into the cardiovascular renal arena. But we are going from single G to double G to triple G to 5G networks. And, part of the tension is that as we start learning more and more about these, we are also understanding that, there's other ways of looking at weight, not just BMI, but other anthropometric measures are probably better. Now there are sort of concerns around loss of lean body mass and gain of weight. And so again, we're going to have to learn a lot more about this as we move forward. But as it stands with heart failure and preserved ejection fraction, the goals of therapy are to reduce clinical events, no doubt. And for that, we had SGLT2 inhibitors in EMPEROR, PRESERVED, and DELIVER, and to improve signs and symptoms. And for that, of course, I think semaglutide is the STEP-HFpEF program that has a dominant benefit here and also has benefits to reduce clinical events. So these are quite valuable in people with obesity-related HFpEF. But, don't forget that semaglutide has all sorts of other benefits. And, I hope this is a word, NONET, or 9 attributes that we know of right now of semaglutide, of not just A1C reduction, weight reduction, MACE reduction in people with and without diabetes, reduction in inflammation, kidney protection in the FLOW trial, blood pressure reduction, reduction in liver fat, but also now what appears to be benefits in heart failure with mildly reduced or preserved ejection fraction. But I think it would be remiss of me not to highlight that the field of HFpEF has seen yet another advance, and I'm sure all of you are aware and have already discussed this at cardiology rounds, and that is the fine art study. And, Jay Udell and myself and Shelley Zeroth were the Canadian national leaders on this paper, and this was the fine art study with finerenone, a non-steroidal MRA in people with heart failure and preserved or mildly reduced ejection fraction. And as you know, the MRA story in HFpEF and HF mildly reduced has been one that has been sort of controversial, to say the least. And again, we have all heard that from various discussions in the past from Gordon and others around TopCat and TopCat Americas and things like that. But we've had no clear sort of picture of whether it would be beneficial in this population, unlike HFrEF, where we have very clear mortality data. So this was a global trial of finerenone versus placebo that was unequivocal, really, in terms of its benefit, in terms of the primary endpoint. This was driven largely through a reduction in worsening heart failure events and heart failure hospitalization with numeric, but not statistically significant reductions in CV death. And therefore, really, I'd like to conclude by reminding us that, many of you are aware and know this better than I do, that it's 44 years ago that HFpEF was defined in a publication, heart failure with preserved ejection fraction. And it's taken 40 years from that point to get the first pillar. We've gone from 0 to 3 in the span of just a few years, with SGLT2 inhibitors in DELIVER and EMPEROR preserved being one of the first pillars, to then now finerenone non-steroidal MRAs, and most likely I would say semaglutide and tirzepatide as the third pillar. So, are we moving from the 4 pillars of HFrEF to the 3 pillars of HFpEF? I don't know, but it seems like the data are pointing in that direction, that we now have more options to reduce risk in this population. And a lot more is coming, right? The ziltivekimab story and, colchicine and other strategies being evaluated in this population as well. So